Hi, thank you everybody for all of your responses to the case of the month. So let me refresh your memory. This was that dense, diffuse white scar, basically, with progressive decrease in vision. So this is kind of an interesting case in general. So the patient has, this is interstitial keratitis, or IK. And now it's at the quiet scarred stage. The reason, and surprisingly, as dense as that scar is, sometimes people can see fairly well through that scar. Believe it or not, to me, when you look at the scar at the slit lamp, it looks like a 20/50, 20/80 scar or whatever. Sometimes people can see 20/40, 20/30, which is bizarre, but they can. However, she had decreasing vision because she developed a cataract. So now we have a corneal scar with a cataract. But let me, we'll get to the treatment in just a second, but let me back up for a second. And let's talk about interstitial keratitis. You don't see it as much anymore, and particularly in this country. It's seen more in third world countries these days. But the main cause of this type of interstitial keratitis is congenital syphilis. And here's the situation. The typical picture is this. You have someone who is an adult now, but has a white scar, generally bilateral. They were born with congenital syphilis, which was transferred through the placenta from the mother to the fetus and then to the infant. They actually, as children, see quite well. And then about age 9 to 12 or so, they develop, out of the blue, a intense acute interstitial keratitis associated with intense corneal inflammation, dense vascularization of the cornea, and usually a very intense uveitis. Then that burns out after a couple of months, actually, if it's not treated. If you see it and you treat it with intense steroids, it generally doesn't scar as much. But for the most part, these people aren't treated. And then they end up with scarring and thinning, and then the deep ghost vessels of the old active vessels that were there years ago. And so this is IK, and it's generally also associated with other congenital anomalies, what they call frontal bossing, which is a flattening of the forehead, or a saddle nose, which is loss of the cartilage of the nose here, and things called like Hutchinson's teeth, which are types of incisors that are notched, or molars that are a funny configuration. So you get all sorts of congenital facial abnormalities in addition to this condition. And so I see this fair bit. They're generally referred in for corneal transplant. So in this particular case, I just wanted to share with you this case of diffuse scarring and thinning and ghost vascularization, which then I'm going to show you a video on I did a transplant and a cataract extraction at the same time. Patient's doing great. So I'll show you that video. Now let's talk for just a second about other causes of acute interstitial keratitis. In addition to congenital syphilis, there's the usual suspects of herpes simplex, stromal keratitis, herpes zoster, stromal keratitis, Lyme disease, as well as Epstein-Barr virus, and occasionally cytomegalovirus, other types of viral keratitises that can cause this picture as an adult. But at any rate, I wanted to share this with you, share the treatment, and just to get us thinking about the various different disease processes that affect the anterior segment. Anyway, thank you for all your responses, and I'm going to send out another case in next month. Thank you.
We are now going to perform a corneal transplant operation for this patient, combined with cataract extraction and placement of a posterior chamber intraocular lens. Notice how the pupil doesn't dilate well because of the posterior synechiae. The first thing that I do is lay down an 8.25 millimeter trephine epithelial marker, which I use to guide the trephination period. Here you can see the trephination, which we bring down to about 80% corneal depth. The trephine is the circular scalpel, but I don't enter the anterior chamber with that scalpel. I enter the anterior chamber with a small blade and then remove the full thickness cornea with a curved corneal scissors. I do that so I can leave a little ledge of cornea at the base of the stroma near Descemet's membrane. You'll see that as we come around with the scissors. That little ledge helps snug the corneal graft into a secure position. Now that the cornea is removed, I'll address the posterior synechiae with a cyclodialysis spatula, making sure that I lyse all adhesions between the iris and the anterior capsule. Now here I am performing a Capsulorhexis. In this case, I'm going to make the Capsulorhexis about 5 millimeters in diameter. Remember, the optic of the implant is 6 millimeters in diameter, so I like to have about a 0.5 millimeter on all sides of the optic so as to secure the lens implant in the capsular bag. I'm then hydrodissecting the nucleus, and I'm going to remove the nucleus with a combination of a forceps and the cystotome. Now I'm removing the residual cortex using irrigation and aspiration. Once all the cortex has been removed, I place a little viscoelastic in the eye and then place the posterior chamber lens in the capsular bag. I then lay the cornea down over the opening, and initially I will secure the cornea in place with 4 interrupted 10-0 nylon sutures. Those are called the cardinal sutures, placed at 12, 6, 9, and 3. That sets the graft. Each knot is done with a 2-1-1 knot. That is 2 passes, then 1 pass, then 1 more pass. For me, that's the ideal size of the knot, and it's very secure. I then cut the knot really short and leave it on the graft side, because remember, there are no corneal nerves on the graft side, so the patient doesn't feel that little knot. So now I have placed the 12 o'clock, the 6 o'clock, and the 3 o'clock suture, and now I'm just placing and now cutting the 9 o'clock suture. I'll then put in 12 more interrupted 10-0 nylon sutures, splitting each quadrant so as to make even distribution between each of the 16 sutures that I will eventually use to secure the graft in place. After 8 sutures, I check to make sure the graft is watertight, that it looks good, which it does. And now I've put in the additional 8, and I'm checking to make sure, again, that the graft-host junction is even all around, that there are no leaks of aqueous, and that the wound is both watertight and secure in the z-axis so that everything is aligned properly. I'm now removing that residual air bubble and making sure that the intraocular pressure is about normal, about 20. And again, just making sure there's no aqueous leak and that the graft-host junction is nice and tight.